Before the narrator takes you into the case, keep one thing in mind. This is not a story about AI replacing doctors. That framing is too simple. The real story is about a healthcare system where the technology to reduce diagnostic error is arriving faster than the system can legally, financially, and psychologically absorb it. So as you watch this, listen for the pattern. The AI is not just being tested against doctors. It is being tested against chaos, messy records, exhausted humans, broken incentives, legal fear. And if the technology works inside that chaos, the next question becomes much harder. Why is it still missing from so many places where patients actually need it?
Imagine a patient rolling into a crowded emergency room. Their health is rapidly declining, their symptoms are vague, and despite their expertise, the human doctors on shift are entirely stumped. This wasn't a laboratory test using perfect data. In a 2026 study from Harvard and Beth Israel, researchers challenged an AI model using messy, real-world hospital records, the kind filled with shorthand, missing history, and contradictory notes. The results revealed a significant performance gap. 2 experienced physicians scored in the low 50% range, while the AI successfully analyzed the patient's longitudinal history to accurately diagnose lupus with heart inflammation. The breakthrough isn't that AI is a magic bullet. It maintains its performance lead even in the disorganized, high-pressure reality of a human hospital. But zoom out from that one case, and you find a systemic crisis that the healthcare industry has largely chosen.
Pause here. The narrator just said something easy to miss. Messy, real-world hospital records. That phrase is doing a lot of work. Most impressive AI demos happen in clean environments, with clean labels and clean examples. But an emergency room is not clean. It is fragmented notes, missing history, rushed abbreviations, and symptoms that do not line up neatly. So the impressive part is not just that the AI found lupus. The impressive part is that it found the pattern inside the same kind of disorder that real doctors face every day. That is why this case matters.
To ignore. The scale of the failure is quantified in this data from Johns Hopkins. Every single year, roughly 800,000 Americans are killed or seriously disabled due to diagnostic errors. This pyramid illustrates the preventable gap. Most of these errors involve the Big Five, conditions like cancer and heart failure, where 2 out of 3 diagnostic deaths could be avoided with more precise intervention. We are living through a fatal epidemic of human error.
Now stop on that number. 800,000 Americans killed or seriously disabled every year because of diagnostic errors. That is not a rounding error. That is not a software bug. That is a public health crisis hiding inside routine medical care. And notice something else. The damage is concentrated in conditions where time matters most: cancer, strokes, infections, blood clots, and heart failure. So when people say, let's wait until AI is perfect, the uncomfortable response is, compared to what? Because the current system is not perfect. It is already failing at scale.
And the digital tool required to stabilize the system is already sitting on our servers. We know this because large-scale implementations are already proving the concept. In Northern California, Sutter Health deployed a diagnostic AI across 60 different clinics. By processing 35,000 mammograms in a single quarter, the network saw cancer detection rates jump from 4.8 to over 6 cases per 1,000 screenings. AI does not share biological vulnerabilities. While an algorithm stays consistent, a human doctor's accuracy sinks as the hours add up. Between hours 8 and 12, performance plummets. Fatigue causes error rates to spike at 3 a.m., regardless of experience. The algorithm has biological immunity. It applies the exact same level of scrutiny to its 10,000th scan as its very first. These capabilities now extend beyond basic image recognition.
This is where we need to be careful. The point is not that doctors are bad. The point is that doctors are human. A human being cannot stay equally sharp through endless scans, chaotic records, time pressure, and a 12-hour shift. At 3 in the morning, attention changes. Pattern recognition changes. Risk tolerance changes. That is biology, not laziness. An algorithm does not get tired. That does not mean it understands medicine the way a great doctor does. But it does mean it can apply the same level of attention to case number 10,000 as it did to case number 1.
Algorithms are now identifying biological connections that have remained invisible to human specialists. Consider the CLAIR system. It predicts cardiovascular disease purely by analyzing blood vessels in your eye. For a human doctor, there is no obvious link, but the AI finds fatal heart risks in an organ physicians aren't even looking at. This is changing the nature of preventative medicine.
The video just gave us the uncomfortable question. If this technology can help with emergency records, mammograms, and even cardiovascular risk hidden in eye images, why is it not everywhere? The easy answer is safety. And yes, safety matters. Bad AI in medicine can hurt people, but safety is only one layer. Underneath it, there is regulation moving too slowly, liability rules that scare doctors, and a payment model that often rewards more procedures instead of faster answers. So the real barrier is not one wall, it is a maze.
Allowing us to see invisible biological warnings before human symptoms ever manifest. If the technology is this effective, why is it missing from your local hospital? The answer lies in these three concrete barriers. The first is regulation. This funnel shows how thousands of viable tools are developed, but almost all are choked out by an FDA process that treats rapidly evolving software like a physical metal scalpel. The second wall is the liability vacuum.
This is the trap the visual is pointing to. Imagine being the doctor in that table. If you follow the AI and the AI is wrong, you can be blamed for trusting it. But if you ignore the AI and it turns out to be right, you can be blamed for missing a warning signal. That is a no-win scenario. The company can say it only provided decision support. The hospital can say the doctor made the final decision. And the physician is left carrying the risk for a system they did not build, cannot fully inspect, and may not be legally protected for using. That is not a smooth path to adoption. That is a legal minefield.
As this table shows, the legal system has no safe harbor for AI use. Whether a doctor follows a wrong algorithm or ignores a right one, they carry 100% of the personal malpractice risk. The third barrier is economic. Under the American fee-for-service model, hospitals are paid for procedure volume. An inaccurate diagnosis generates revenue through repeat visits and scans. A perfect day one diagnosis eliminates those billable procedures, making accurate AI a threat to the body.
Now this is the part that sounds cynical, but it is central to the story. In a fee-for-service system, the hospital gets paid for activity, scans, consultations, follow-up tests, procedures. A slow diagnostic journey creates billable events. A fast, accurate diagnosis can eliminate them. So an AI that solves the problem early may be great for the patient, great for the doctor, and terrible for the revenue model. That does not mean every hospital is acting in bad faith. But it does mean the incentives are dangerously misaligned. And misaligned incentives can keep good technology out of the room.
Bottom line. These barriers have nothing to do with patient safety. They are designed to protect legacy bureaucracies and institutional profits. This creates a surreal global paradox. While American hospitals are paralyzed by red tape, developing nations are moving at the speed of the technology. In regions with a desperate shortage of doctors, these advanced AI tools are already acting as primary specialists. In places like Kenya, necessity has simply overridden the friction of legacy systems.
Before the narrator closes, here is the practical takeaway. Do not use a chatbot as your doctor. Do not ask it to diagnose rare symptoms, manage complex drug interactions, or handle psychiatric crises. That is not what consumer AI is safe for. But do use it to become a better prepared patient. Ask it to translate a confusing lab report into plain English. Ask it to organize your symptoms into a clear timeline. Ask it to help you prepare better questions for your appointment. The goal is not to replace the doctor. The goal is to walk into the room with better information, less panic, and a clearer understanding of what to ask next.
Back in America, you sit in a waiting room, relying on a system that is structurally misaligned with modern technological capabilities. The technology to save your life is fully operational today. Your healthcare system is just terrified to plug it in.